right, so we're going to be finishing up chapter 21. A lot of this information kind of goes hand in hand with the stuff that we've already talked about in chapter 21, still talking about how we can describe the quality of the image. So we talked a little bit about image detail factors or the quality factors rather, as well as factors for the geometry of the image. We can now talk about subject factors, which we've talked about somewhat in different ways. But basically these involve the patient more directly. Things like the patient thickness and the density of their individual tissues within that body part. The shape of the object, which in this case is the patient or their body part, and motion blur, which can be either voluntary or involuntary regarding how the patient is moving. So it's not necessarily associated with their position like something with geometric factors would affect. Say like they're tilted or not completely perpendicular to the central ray or parallel to the IR, causing distortion, but rather associated with their body and their body parts. So we can differentiate radiographic contrast and subject contrast. We've talked about subject contrast already being a direct result of the differences in attenuation in bodily tissues. Remember that areas that have high subject contrast are things like the chest, where we have body tissues that are at very different levels of contrast. Bone, very high radiopaque density versus something that's less dense like air. So we have a very black and white image. Something with low contrast is more so something like the abdomen, which we've given as an example previously, where we have a lot of different kind of mid-level shades of gray. Radiographic contrast, however, is the product of the contrast at the receptor from the technical factors we put into the console, as well as the subject contrast of the body part that we're looking at. So it's based on both. Now, there's this concept called post-processing that really is only applicable to digital receptors. You can also, I guess, take CR machines and do post-processing to window and level. It's something that we can do for radiographs. It's something that we do much more frequently with CTs. But I'll show you what that looks like. So this is an x-ray that I took of somebody's lumbar spine. Notice that it is free of patient information for HIPAA reasons. But notice they also had a bunch of metal on them. They were not properly gowned. But we can take this tool, this is in the post-processing because it's after I took the image, to change the contrast. So I can make it more gray, I can make it darker to see better shades of gray. So this is really something that can help with radiographic contrast, but it's not something that you should kind of rely on if you get poor contrast images from not collimating appropriately or using proper technical factors. Sometimes even when you have a perfect image of a patient, but is otherwise the collimation's much wider than it should be with a very thick patient, it can be really difficult even with window and leveling to see the anatomy as you need to see it with enough detail. Okay. We've talked about how when we have a thicker body part or a thicker patient, that we need more x-rays to penetrate those tissues. Otherwise, those x-rays kind of get lost in absorption in those thicker body parts, and they never actually reach the IR. So in this case, we have the same number of x-rays starting off going through the patient, but because this one is a little thicker, because of that turkey, not as many are reaching the IR, which would lead to a difference in contrast. So you can imagine that the x-rays that are absorbed and attenuated, we're going to see kind of a lower contrast image for thicker body parts. For tissue mass density, this is the concept of different sections of the body having perhaps equal thicknesses, but different mass densities depending on the types of tissue there. So some certain tissues in the body might have just more fat or more bone or more muscle density than other tissues, more organs. And all of that, based on their atomic number, are going to be demonstrating different radiopacities because of their densities. So this is just an image of a bunch of different fruits and vegetables to show you that even though they are all fruits and vegetables, they all show different shades of gray depending on their actual compositions. And the thing that goes hand in hand with this is the effect of atomic number. Because each layer of tissue, each type of tissue is going to have a slightly different atomic number, it's going to result in a different amount of absorption of X-rays. So higher atomic number tissues will have more absorption and vice versa. So the photoelectric effect varies in proportion to the cube of the atomic number. I'm not going to make you do the math on that, but I do want you to understand the concept. If adjacent tissues have very different effective atomic numbers, that's when subject contrast is high. So think of things like the chest. When we have air next to bone, their densities are going to be extremely different because the atomic number of the components of air versus bone are going to be vastly different. When we use contrast media, for example, iodine, barium, when we inject contrast, or either they take it in orally or rectally, it's going to enhance the subject contrast of the body part that we're looking at. So it'll accentuate that through enhanced photoelectric absorption, causing a little bit more brightness on an image. So this is a CT scan. We know that because the bones are white. This is an axial view of the abdomen, just for your own fun and reference. When we look at CT scans, they're always going to be inverse. So this is patient's right, this is patient's left. Anterior and posterior still remain the same. So this is the spine here, and the central canal where the spinal cord would be. All this kind of white stuff going around the side are ribs. It's just kind of one rib, but we're seeing it in multiple sections of the rib that's going around them. But on the right here is the liver. This is part of a kidney. This is a kidney. This is the aorta. This is part of the stomach. And then this is the pancreas here. We can see a little bit on either side of the stomach here of intestines. But notice in particular when we're looking at that pancreas, it's an area of high metabolism. So a lot of stuff is going on in the pancreas. It has both intestinal functions as far as releasing enzymes for digestion, as well as releasing hormones throughout our body. So looking at the shade of gray here without contrast, and then the shade of gray here with contrast, it's lit up quite a bit. We also have this saying that contrast goes where blood flows. So wherever we have really nice kind of vascularity, we're going to have a little bit of increase in contrast. So kidneys are highly vascular. You can see the difference between them pre and post contrast, as well as the liver, much brighter, but less significant obviously than the kidneys. And then the aorta holding the blood makes sense that it would be pretty bright there too. Object shape also has a pretty significant factor on the subject and how it will appear as far as contrast is concerned. In a perfect world, if the shape of the object coincided with the shape of the X-ray beam, then the subject contrast is maximized. So it would be a perfect kind of contrast. It's as high contrast as it's ever going to be. However, the varying thicknesses depending on the shape of the object will result in contrast being higher in certain areas and lower in other areas. So overall kind of reduced contrast because of the attenuation that happens within those tissues that the beam has to penetrate. Motion blur. So we've talked a lot about different types of blur, so make sure that when you're talking through your homework, you're not just calling it blur, because there's a bunch of different reasons for blurring of an image. It's not the same as noise, although noise will make the image blurry. Poor spatial resolution will make the image blurry. Focal spot blur will make the image blurry, but so does motion. And this is why we tell the patient to hold their breath, or to not move, not swallow, things like that. So patient motion themselves is the cause of motion blur, and it can either be voluntary or involuntary. Remember that when we're taking abdomen x-rays, we're telling them to hold their breath on expiration and then waiting 1 to 2 seconds to try to account for that peristaltic motion that's occurring through the abdomen. Their heart beating, spasm can also cause involuntary motion blurring artifacts. Voluntary motion can happen especially with young patients. Sometimes we'll keep parents in the room with really young pediatric patients who have a hard time holding still, especially if they're feeling really anxious or in a lot of pain. And then breathing artifacts, of course, which is why a lot of the times when we're doing imaging around the chest, we try to make sure that patient is holding their breath in a way that's advantageous for the thing that we're trying to image. So how do we reduce this overall? If we have a shorter exposure time, patient has less time to move, therefore there will be less motion blur. If we need to restrain the patient per the doctor's orders, then we can do so. Sometimes we'll have to do that with pediatric patients, but oftentimes the parents can act as the kind of restraint that the individual needs. Having a large SID is going to decrease distortion, and have the tube a little further away from the patient, decreasing motion blur overall. And similar with OID, if you have the patient against the bucky, then they're probably not swaying super much. Sometimes they will be, but that will kind of decrease that effect. So overall, how do we make a really good image? Patient positioning is obviously very key. Selecting the correct image receptor and selecting the correct technical factors. Of course, keeping exposure time as short as possible helps a variety of factors, including motion blur, which we just talked about. So for patient positioning, as close to the IR as possible to minimize OID, to minimize magnification and distortion. We want the axis of the structure lying parallel to the plane of the IR, which is why we always make sure that the IR is lined up with the central ray, because the central ray should be perpendicular to the object being imaged. The patient should be properly immobilized, meaning that you're giving them proper breathing instructions. And if they're super shaky, especially in something like an extremity, we can use a sponge, a wedge, or even tape, like we said this week for the digits, in order to properly immobilize and make sure that there's no motion artifact. In digital radiography, like what we've been using in our lab, there's not really a different size of IR that we can use to really fix the number of pixels, but just note that smaller pixels will increase radiation dose to properly expose the patient, but it does result in a better image. So there's usually a toss-up between what's best for the patient and what's best for the image. And that's really the entire crux of X-ray physics. How do we balance the dose to the patient and having a good image? Selecting proper technical factors, again, keeping time short to reduce motion blur. As we increase KVP, remember KVP is the prime thing that affects intensity. So the higher intensity beam, the more energies increase and the more x-rays are produced. So remember, it's the principal thing that affects quality. It also affects quantity, just at a lesser rate than MAS does. So if we increase KVP, higher proportion of the beam actually reaches the IR, but as we increase KVP, scatter also is going to increase. So we'll have less kind of differential absorption, lower contrast, less X-rays actually making it to the IR rather than being attenuated and kind of interacting with one another. So that'll increase noise. So again, it's a balance. We want enough X-rays actually reaching the IR, but not so much that we're having all of these different interactions between the X-rays. Increasing MAS will increase the dose to the patient as well at a much higher rate. But if you have a larger patient or a thicker body part, it might be necessary to get a proper image. Otherwise, you'd have to irradiate them again, and that is an even more increased dose. Make sure you spend some time on these charts. They tell you in detail for distortion, spatial resolution, and technical factors, how they apply to different factors. Notice that all the ones that say 0 means that there's no effect. And if you just want a summary, all the verbiage is over on the side. But for distortion, the primary things that affect distortion are SID and OID. Nothing else really has an effect. So as we increase SID, we lower distortion. But as we increase OID, bring the object further away, then we increase distortion. So for SID and distortion are inversely proportional versus OID and distortion that are directly proportional. For spatial resolution, most of our things that affect spatial resolution are SID, OID, focal spot size, pixel size, and patient motion. So those are pretty self-explanatory if you really think about how those would affect spatial resolution and therefore our ability to see a really clear image. And this is probably the biggest one. It's probably the most comprehensive. So it kind of tells you in detail what happens when you increase each of these factors and how they affect IR exposure, contrast, spatial resolution, and distortion. It's a lot of things all at once. So what happens to the IR versus what happens to contrast. As we increase KVP, we decrease contrast, etc. So make sure you know those tables pretty well. There will be a lot of relationship style questions on your exam.